Okay. Richard?
Thank you, Joel.
David, rather.
David. Along with Richard, I also started as a philosopher. I don't know if you knew that.
No.
And then went to medical school, but instead of being smart and going on to law school, I actually went to get an MPH. Joke. When Jeff Lerner asked me to join this panel, I asked him what the title of the panel is, and he said it's about underserved populations. I asked the question, do you know my background? And genetically and familially, I'm related to Jack Wennberg, and I've done a lot of work in small area variation. And if those of you who have followed the small area variation, the literature and the work that's been done from that area, we feel much more along the lines that Richard brought up, which is that there's overdiagnosis, overtreatment, and that in general, most of the time when people talk about underserved, it's because they don't really understand what patients want or need, or that the outcomes may actually be, that more is not necessarily better. And so when I heard that from him, and I learned about overdiagnosis from Gil Welch, who is not only a brilliant researcher, but an unbelievable storyteller. And he taught me how to write my first paper. And so when I talked to Jeff about that, I said, you know, that's not really my gig, the underserved, that is. Not that I don't think there is underserved issues. And he said, but aren't you working in an organization that's looking at access to high quality, efficient mental health services? And it's sort of 2 steps late for the philosopher to light bulb to come out and said, yes, that actually is an issue. And it's a different spin on what people usually think about underserved. And so I'm going to weave a little bit the challenge that we had in terms of underserved issues and standardized workaround issue in terms of the mental health. I'm also going to start with a little bit of an anecdote, similar to Richard was, but unlike Richard, I actually gave up medical practice many years ago, so I'm going to talk about something that happened much closer to me, which is one of my daughters. And the reason one of the primary reasons I ended up going to Quartet, and Quartet is a company that's focusing on what we call virtual integration of behavioral health and physical health. And I'll come back to the model that Richard has the luxury of having having a mental health provider within the practice, which is very rare in the country at the end. And the story about my daughter is that, like a lot of folks, she is, who's both parents, physician and lawyer. She's highly motivated. Graduated with honors from college, went off and did the Camino, which is the walk in Spain, and was ready to do her launch into her first career. And she had in the past, and I had permission to tell the story, and so for those of you who know, it's actually written in a blog with her permission. She came back, and she's actually had a fair amount of times where she's had seasonal affective disorder, quite severe, and such that she's been medicated multiple times and has been in therapy as well with that. When she came back from the Camino, she was full of vim and vigor, but about 6 weeks later, she called me and said, you know, I've got that thing again, and I really need help, and it's much worse this time. I don't know really what's going on, and I think I need to do something I've never done before, which is actually go to see a psychiatrist to support in some of the medications that I need to be adjusted for. Now, this is a daughter of a physician and a lawyer who is very well insured, who, for all outside world, has access to all the medical resources, and actually, because I do enough work around the country, not quite around the world as much as Richard has done, I know a lot of practitioners and a lot of healthcare systems in most of the major metropolitan areas that in the United States, and she was in DC. And so I actually had to scramble pretty hard to find somebody who would actually take care of her, because it's very hard actually to get to a psychiatrist. But she did get to a psychiatrist. He did a test he didn't need to do, which was very expensive, but I didn't fault him too much in that, because he actually did switch around the medications, and she had remarkable recovery. Now, one of the medications she was on was was clonazepam, and clonazepam is a fairly strong anxiolytic which she needed at that time in the transition. But it has one of these nasty things that if you stop it and you don't taper it right, you can have pretty severe withdrawal syndromes. So she had gone through the course, switched over to her new antidepressant medication, and then it was time to stop the clonazepam, and she basically was told by the psychiatrist to stop the clonazepam without a communication to the primary care physician, in fact, not even writing down what the plan would be. My daughter is incredibly performance-oriented. So she heard, stop the drug on January 1st, and she stopped the drug on January 1st. but she didn't do any taper. So about 36 hours later, she called me back and said, Dad, I'm having this really weird feelings. I don't know what's going on. She described what in fact was classic withdrawal syndromes from clonazepam. And I said to her, I said, call your psychiatrist and let him know what's going on, which she did. And she got a voicemail, answering service to a voicemail, and then got nothing back. So 12 hours later, she called me again and said, Dad, I'm feeling worse. And I said, did the psychiatrist call you back? And she said, no. And I said, well, please call him again and leave another message, which she did through the answering service. And she did not hear about that. The next day she called me back and she said something that no parent ever wants to hear, which is, I'm going crazy and I need a plan. And I said, at this point, I'm going to call the psychiatrist. So I got the psychiatrist, got the voicemail. Answer service to voicemail. Said, this is Dr. Wennberg. I'm calling on behalf of one of your patients, about one of your patients who happens to be my daughter. And literally 10 minutes later, I got a phone call back from the psychiatrist. I'm not going to go into it about how doctors are much more responsive to doctors sometimes than they are to their patients, although I guess, said that. And basically she said, I never told her to stop it. I told her to write it to a taper. And I said, well, did you write anything down? And he was like, no. Did you have any communication by any other ways which actually documented it? And the answer was no. And he did what he had to do, which he started back in clonazepam, did a taper, et cetera, and she's all great and fine, and she's like, flying to law school and blah, 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 blah. She's actually my roommate in New York, but that's a different story too. But I learned a lot. I already knew a lot about that. That story in some sense is the reason why I'm trying to focus on what I'm going to do. The first one is that despite having all the resources, she had a hard time getting access to care for mental health. The second thing is that there was no communication between her primary care physician and her mental health provider when there's this weird thing that the mind and body are actually connected. We actually try to call ourselves the Descartes company, but not everybody really figured that out. Actually, particularly the 27.
Very elite group.
Exactly. The third thing I learned is that, and I already knew this because even though I don't practice anymore, I've been around physicians for long enough, is that we may be patient-centric, but we're not very person-centric in terms of how we think about communications and working with people. And the last thing I learned is that if we're going to get better access to mental health providers, it's probably more appropriate and easier to find out a way to actually create collaborative care than it is to train every father and or mother to be a physician to intercede on behalf of their kids. And so I came to an organization who's doing something that I think is quite interesting and related to the workflow issue, is that what we're doing is we took the tenets of the work that Richard has done, which is the actual integrated, co-located model, which has been around for about 30 to 40 years in the literature with a fairly large body of literature that says people do better and they save money if you create collaborative care, i.e. physical and mental health care together. But like a lot of good ideas, it's been very hard to disseminate. It's hard to get the data. Richard, you may know this, but my estimate is that less than 10% of primary care practices have co-located collaborative care. And there's reasons why. You actually talked a lot, but it's very hard to get reimbursed. It's also administratively difficult. And the part I think that people miss is that there's this huge divide, if you will, not just because of payment issues, but because of training, because of organizations, because of the associations between physical health providers and mental health providers. And so even just trying to convince enough people to join practices to do that is very hard. In fact, I don't know if the Kaiser folks are here, but Kaiser in California has had hundreds of open applications for mental health providers within their systems, and they just have a hard time to negotiate and do that. And so despite all the vertical and horizontal integration that's happened within the healthcare delivery system, there's almost been no integration or either horizontal or vertical with the mental health providers. And so what you end up having is two basically very different organizations, or organized bodies, if you will. I use organized in a loose term, trying to help take care of people if they're going to do it at all. And so there's a couple ways of addressing that. One is you can actually try to fight a battle, which I think is very hard to do, and which is to actually create co-located models and across the country. That also presumes that all patients want to be seen face-to-face and during the office hours. Or you can try to do something a little bit different, and it's a little bit controversial, which is actually use what's becoming a little bit of a negative word out there, which is platforms, which actually can create scalable communications and collaboration, which is data-driven, and basically address the collaborative side, not so much by moving people and organizing them within their own practices, but actually creating a platform to do that. Now, the challenge of doing that is that with the workflow, you're actually asking an interesting process from the workflow. The first one is you're asking docs who are a little bit, and you should talk more about this, Richard, again, is that overburdened with the solution called electronic medical record to do something which is outside of the electronic medical record. The second thing is you're actually asking doctors to do something that they're not very well trained to do, which is actually think about and address mental health in routine practice. And then the last part is you're asking physicians and mental health providers, many of them are not MDs, the psychiatrists are actually very much the minority of mental health providers, to actually work together in a team. And that's sort of not exactly, they're not really on the same team. And so we've tried to do this, and we're still learning a lot, by basically identifying and making it easy for primary care physicians to actually ask the hard questions. I mean, if you look at the performance measures that are out there, there are several of them around mental health, almost always at the worst in terms of completion. And it's not because docs don't want to ask about that or don't think mental health is important. But if they ask the question, they actually feel, and which I think is appropriate, obligated to do something about it. And the workarounds about getting people to mental health providers so overwhelming that most docs would rather not ask the question and then not have to deal with the thing than they are about asking the question and not being able to deal with it. And so what we've done, and I will say when I came on, my biggest skepticism is that this workflow issue, particularly with EMR, would be too difficult to do. I've been pleasantly surprised that that's not true, and I think it really reflects several things, and then I'll stop and turn it to Kimberly. The first is that mental health now is no longer a verboten word. People are actually willing to do it, and they're asking the question. The second one is that the prevalence of mental health, even if you just look at depression, anxiety, and substance use disorder, is higher than the combined prevalence of the usual suspects that we think about with big chronic illness. I'm leaving out hypertension, which basically everybody has now. The third thing is this, that docs really do want to take care of their patients, but if they have no solution, they'd rather not ask the question. So if you give them something to do that, they'll actually do that. And the last is that the workflow doesn't have to, and workarounds doesn't actually have to be about the physician. I mean, if you look at this right now, is that, and we decided not to do slides, but we have some very pretty slides of pre and post, which is, it's the front office staff right now that deals with the workflow about referral to mental health providers, because these providers are not in the EMR, so you can use your Epic referral thing, but it sort of goes into that Epic Everywhere, which is a great marketing thing, but no one actually uses it if they're not part of the systems with an Epic. And so you have this wonderful picture of the front office screen with yellow stickies everywhere. 3/4 of them are about mental health, trying to get people to the care. And then the post one is basically all the stickers are gone, because they actually is a way of actually doing this through a technology that actually gets people to the care much quicker and more efficiently. So the work, and so that was actually the solution in an ironic way about the workflow issue, is it's not about the doctor, it's about the team. Not that everybody wants too much of a team, but if you can make the front office happy, you make the doctor happy. If you can make the doctor easier to identify it and then refer patients with a big burden of mental health to somebody else, and they get information back in a way that can be helpful to them, it's easier for that standpoint. And the last part is that we can also make this much more patient-centered care by identifying their preferences in terms of language, gender, channel of care, up front before we make the referral. And I think there's a huge promise from that perspective, and it actually is I think is an under-realized opportunity to address the underserved population in a way where we don't create overburden on the workflow.